care physicians can easily follow. A high school degree diploma person can be in your clinic and do most of the job. This is also part of our task, to modify it and make it pragmatic. And the reason I started with 35 to 45 here to begin with, this is the range that we have most difficult part in initial assessment, because the older you get, the more lean I am towards PK's approach, which you can now put a big bill. You can start with a calcium score or IMT or an imaging. But in this range is where you really have a hard time to put a structural imaging or disease management, because disease has not occurred yet. This is where we still have room for risk factors play. So if we are able to cluster this population out up to 45, then when we go to 45 to and above, we can start a new argument that here, where the pretest likelihood is very high for disease, should we start with an imaging or so? Do we agree on who to be taken to the next level of the base of the pyramid from here?
Do you know what you mean by fitness test?
Oh, it's a 6 minutes walk test, or the Cooper Clinic has a fitness test. You just go and measure your heart rate, and if you don't match the heart rate that is considered fit.
Do they have finger sticks for CRP?
No.
Can we do a little survey and see how many people think
Just
CRP?
about.
I think we should have Dr. Koenig make
Okay.
a comment
Well, yeah,
on
we'll have.
CRP
Yeah.
before we. I mean,
Well-
he's done a huge amount of work.
Yeah. I think with regard to CRP or any other biomarker that we might concern, we just don't have the data, enough data which really convinces us in what part of the population to do that. I mean, there is 2 or 3 studies right now which suggest that in addition to the traditional instruments like Framingham, for example, we can do better and differentiate, especially in those at intermediate risk. But we have seen, and Paul sees, a considerable improvement across the whole range of the Framingham risk categories. But still, that has to be replicated in other studies, and I know that a number of those are still under progress now, like, for example, ERIC and so. So the database, also there is, I think, enough prognostic data on C-reactive protein, for example, compared to other markers. The data that clearly show that it gives additional information is somehow limited and should be replicated in others. And I think that's also true with the imaging methods. This is true, for example, with IMT. We're always talking about IMT. IMT is in the guidelines, but as far as I know, there is no data that really shows that the measurement of IMT, in addition to Framingham, gives you a better prediction. I think that the Leary paper in the New England Journal, they didn't adjust for the components of the Framingham score. So, I mean, whatever marker we use, and which in single studies seems to be useful, we have to put it in the whole concept. And I think we are a little bit, we are not at the right point in time to have successfully integrated all the different markers. I mean, some of these markers really reflect different parts of the disease, reflect different important functional information. And I think what we should achieve in the near future is to really, in a prudent way, combine these markers and get complementary information about this clearly multi-causal process.
But don't you agree that we will never get to a point that we'll have a beautiful, clear picture from the statistics and longitudinal?
I mean, the whole medical business is decision under
exactly.
uncertainty.
So the bottom line is, let's sit down here, and Harvey, I'd like to invite you to this agreement that CRP is a $12 test, and $12 test is what it costs for the actual, economy. Whatever comes out of this, let's say half of what he was told is correct. I think it's reasonable to incorporate that in your early stage screening, where you have Framingham, like, plus. Isn't that
If the specificity is so low that it
And
leads to
I don't
promoting a
happen-
lot of people to the next level erroneously, then no, it's not a good idea.
I don't happen to think that what your CRP matters unless you've got vascular disease. If you have vascular disease, the CRP is a marker for accelerated progression. And then it becomes important in determining the aggressiveness, I think, in which you treat. I mean, maybe it's a little bit like having a calcium score. You're more aggressive in therapy, I suppose. Although if we treat early disease with maximum aggression, then there's nothing else you can measure. What's the difference? You're treating them anyway. And I have a little trouble knowing at how each incremental test adds to the information that I will use in managing the patient. I know, John, you kind of addressed some of the things you do, but it didn't really clarify in my mind how it would help me to know whether the CRP is elevated, unless specifically reducing CRP is valuable. We don't know whether it is. And of course, we give statins which lower CRP, so I guess in a way we're treating CRP. So there's a lot of unanswered questions, and they will be unanswered forever, I suppose.
But
we can work toward
this approach from the cost point of view, and this you're given this $1 billion and you're going to spend it, and there is some data, and you have to go with the data, with what is out there. I think what we have for CRP, and with the enhanced data that is showing 76 million high CRP, and with the follow-up studies, and our problem of 35 to 45-year-old, where you can't put stents, you can't put that kind of aggressive, intervention. Don't you think that if we put this cholesterol profile along with CRP to start with, and stratify people percentile, and say top 25 percentile in this category would go to the next level, the remaining would go through the lifestyle modification or whatever it is, and
No,
just
I don't think that's the proper way to distinguish who should go forward and who shouldn't.
okay. What would be this? Because we have in the handout the problem with absolute risk versus relative risk. The problem with absolute risk, as Erling put in his comments, is if you get a 35 or 30-year-old, 35-year-old male who's a smoker as hell, whose cholesterol is 300, and has a borderline blood pressure, according to Framingham, he's low risk because of the age factor. We all know. The problem here is if you turn that absolute risk to a relative risk and tell them, look, comparing to your normal people in your age with low cholesterol and no smoking, your risk is 3 times more. So you fall into a very high risk category based on relative risk.
Well, you're on a trajectory, which is the relative risk.
Okay, so should we agree on using relative risk for this population, 35 to 45 or 50, this where the age factor would not dominate, and then after that take absolute risk, because absolute risk helps us to actually implement. Is that something that?
Let me just make one comment about CRP. As far as I'm concerned, it's the old-fashioned SED rate. And the fact is that what we learned when we were students is that the SED rate is normal. That's pretty damn good. The SED rate is high. What do you do?
That's fine. Which one is more expensive?
No, it doesn't really matter. I'm just
So,
saying is that,
well,
that
it is-
even the recommendations from the AHA thing, whatever it is, said you need 2 CRPs in order to make a sense. So please incorporate into that, again, if your CRP, whatever it means, is, quote, normal, that's probably useful information. If it's high, I'm not sure what that means, and I'd like to...
Because that's what the algorithm would say go on to the next step. So
Yeah.
if we trust in normal CRP, then it's useful as a screening test. I don't know if we can based on the data, but if we can trust in normal CRP, which supposedly you can, if it's low, then you can be more reassured. We can eliminate, as PK was saying, we can eliminate a cohort of patients who might not be there.
They're very insensitive. I mean, lots of
Yeah,
people
unfortunately, I
have
think
advanced
CRP
disease with
doesn't
normal
have that
CRPs. So you would miss If you use that to screen people, you would be neither specific nor sensitive.
Right, I realize, but I think what, Mort's initial proposal, you have to start with something that's cost effective, and if it's gonna be something inexpensive, it's either gonna be ankle brachial index,
Oh,
it's gonna be
no.
CRP. No, I'm just saying,
you know that's not
I'm not saying which are the best, I'm just saying,
Well,
it's gonna be something cheap, it's gonna be ankle brachial index, it's gonna be
Advanced.
adding the BMI to framing hand, or it's gonna be CRP, and I think CRP is the most attractive.
Exactly. See,
Based
that-
on the available data.
based
we
on
have.
available data, that's exactly what I'm saying. Based on it, and then 5 years later, we'll have microalbuminuria, and we'll have.
Many of us would probably suggest that if we had a measure of endothelial function, that should be discrete.
Everybody would agree.
Therefore, rather than doing CRP, why don't we focus on how to assess endothelial function?
Yeah, we are gonna do that, but now, go ahead.
Could we have your pyramid again?
We just
More,
keep in
more,
mind.
I'm gonna ask you a really very, I have to ask you. I suggest that we dispense with this pyramid. I suggest that, I know too little about the AEHA to know whether this is possible, but I think that this is really what we're discussing, because what we've said is that this pyramid is wrong. This is just too traditional. What we're saying is,
I think that's exactly his point.
PKs,
This is too traditional.
yeah, PKs
It's a
suggest,
critique.
oh, you're saying it's a critique.
No, well, what I'm saying
He's
is,
saying this is what we do currently.
this is what we do
Problem.
currently. We
He's
want
identifying the
we want to be able, what is being done currently based on the data that he's not comfortable, most of us not comfortable with, how to change that we can talk to you as preventive task. I cannot talk with his data to you as preventive task force. Nobody else can. So let's say with what we have, and consider the cost, because that's the most important part, more than 0.00 p-value. If we can have those two incorporated for what is available, and then as part of our guideline, we're going to go a provocative way to say, if you had a way to measure endothelial function, you wouldn't have to mess up with all of these things that is just wasting your time. That's what, then we would push that way. Now, your point is, we can't add anything. Go ahead.
My point is that we should look at PK's sliding, and we should say that the initial thing is to look at vessel disease, or the condition of your vessels.
Okay.
Then we go to cholesterol and blood pressure, no longer as ways to assess risk. No. As ways to modify.
Yeah.
Correct.
As ways to treat.
Oli, I'm 100% with you after age 45 or 50. But I'm very difficult. I have a hard time to think that we can go between 35 to 50. So if you agree with
Because
me,
what? Why is that?
because huge population, 35, imagine we go out and tell everybody at age 35 to 45 or 50, you have to start with an imaging. I mean, it's going to be very difficult. I mean,
Well, we're arguing about the imaging as part of that. I mean, I think we can talk about what should be the first step.
well, again,
Conceptually, there's no reason why we can't do that.
use something that we have data for. Because of
No, let's get data on what makes
No,
sense.
I'm 100% with you on the second part. We keep missing the boundary between the. We have one part in our guideline that we want to push for the new paradigm. We also have another part in paradigm that he is provocative, saying just change. These are the blocks that you have. Just change the order and use it. I agree with you. I want to use that after age 45 or 50, where we have
But I think, as
substantial.
Oli said, maybe we shouldn't be doing a guideline. Maybe we should be talking about what should be the guideline in the future, because who are we to make a guideline? Nobody appointed us.
Oh, no. Well, there is a point here. We are in a position that if we can come up with something that's reasonable to get everybody's signature on it, I promise you we can make more impact on public than AHA or ACC guidelines because of the fact that we're thinking differently and we're bringing something in a more productive way.
But I don't want to sign my name to 19th century
No, I
ideas.
agree. Well, that's what you're discussing. I mean, you are here to shape that. And we start with something that I think what Oli and Pika now are resonating. I love to have that kind of concept to begin with, the disease imaging, and you're saying subclinical disease imaging. I think we should split our population from 35 to 45 or 50 to approach different way. Why? Because in this group, we're still playing with the risk factor. Because we can play with the risk factor, read the risk factor.
Why don't you go ahead to that group?
I don't
If you
think
go
it's
ahead,
necessary to segregate
yeah.
simply on the basis of age. So start, say, why not say
Because this is-
35 on?
Okay.
Why create two subgroups of age? That's
but
how
I think it has to do, it comes back to economics and reality. And so I think if we could maybe come back to this group, because I don't think it's that's not where most of the MIs are occurring.
Right.
Come back to that group. But go to this group now where you're going to come up with something new. Go over 45
Okay.
and see what you would.
45 and above. I was thinking just like what PK brought, that we start with, and I keep imaging. Please don't be sensitive. If you don't have
Yeah,
imaging,
it
that's fine.
wasn't,
Anything.
it wasn't
I
meant
just
to
don't-
say, it was meant to say structure
Oh,
and
I'm-
function.
Structure and
Yeah.
function.
Yeah.
And the imaging is, we
Yeah.
do imaging.
Yeah. So-
We do imaging.
So we're saying, after this age group, which during this time, disease has already established itself. And now, if you start with imaging disease, you have a very high likelihood of picking up disease. Whereas 35, you still have time to develop the disease. So start with an imaging, and I would say calcium score. And based on that, and the percentile that you have, come up with a stepwise top 25, top 50 for aggressive, and lower than that, come back 5 years later, and so on. This is the bulk of change. We didn't start with that, and probably that's why you thought this is the bulk of change. In this group, we're not going to go with the routine. We're not going to go with CRP or coronary Framingham risk score. We want to start right off the bat with an imaging of disease or subclinical disease.
Structure and function.
Oh, structure and function. No, it's structure and
You
function.
leave the word
No.
imaging out.
Structure and function. It can, whatever. And now my point here is, let's help me to find that cut. I said 45. Are you comfortable with 45?
45 in men and 55 in women.
55 in women.
Well,
No, that's too late.
No, but look, this depends on the methodology. Even FH children have modified endothelial function. So in principle, even children can their vessels can be assessed as reflection of their cholesterol levels. So I don't think there's any, in principle, there's any reason to say that there's a lower limit. I mean, within reason around. But again, I think that what we should arrive at is the concept, and not necessarily a practical screening technique anno 2004. I suggest that we formulate a concept or a paradigm, which really is very, very different from
Traditional
Traditional
physician.
guide.
the NCP and the
Pointing out the limitations of the current paradigm, and this is a proposition for looking at out of the box.
I agree, but again, we're not using the data that is available in our hand, where I think we can just go one step further, design this paradigm, new paradigm, based on this imaging of structure and function and subclinical disease. However, with minor changes in what it is being practiced, regardless of what we think, there are people stepping into MR scan, vital imaging, they're doing this heart scan without having this stepwise guideline. We're playing your input here. If we can put something more reasonable and less idiot approach that some of these practitioners and non-practitioners are doing, we can do better. We can help with risk assessment. This is not to disregard this new paradigm approach, because PK knows I'm a big fan of endothelial function assessment, because that's where the disease is. If you're able to monitor endothelial function, and you'll be able to do it at a low cost and repeatedly, just like blood pressure, you basically measure the fever of the artery. And that's what I sort of analyze. But we're not there. We can structure this and force everybody or push everybody and encourage everybody to fill in this gap. But that gap might take a decade to fill in. We all know how long it took us to just come here with Framingham or CRP. Whereas with some minor changes, let's say we here agree that after age 45 or 50, the first step of assessment, risk assessment, has to be a structural functional imaging. And today, we have these, calcium scoring, IMT. We encourage others, and we can come up with two options, recommended and optional. So if somebody wants to do optional, they can do more than recommended, and just go forward with that population. I think our problem would be between 35 to 45 or 50, where it's going to be really economically very challenging to come up with a cost-effective package. But after that, starting with imaging can be really, justified. We don't need to mess with CRP for detection because we're not lowering CRP. We should measure cholesterol because we're going to measure it to bring it down.
You can measure arterial elasticity for $10.
Yeah.
And it's a very sensitive screening
We
technique.
put them in.
So why are we doing Framingham score if we can actually look at it for endothelial dysfunction, which is what happens when you
See,
have endothelial
as much as I would like to be with you, I think we don't have data to say that endothelial function and elasticity are the same. And the challenge that we
Well,
have...
actually, we do have data.
Well, we have some data. I'm telling you, I'm with you, right with you, because I have this new technology that's measuring exactly the same thing that you're saying.
So let's focus on the future rather than on the past.
We are going to focus on future, but how can we add the imaging part, the structural and functional imaging part, to begin with? Now, at the end of the day, we can come up with if everybody agrees that we should start with putting our own game out, right away. We can do that, but let's just go with what we have in our hand, and everybody agrees. We can talk to people outside this room.
Well, just one point of this question that is presently ongoing. I mean, I'm very much in favor of functional and imaging testing of vessels because from a biological, I completely agree. From a biological point of view, it makes sense. But what I don't understand from the approach is, let's say we define any cut point with regard to age, and then you would do your functional testing or your imaging test. Let's say this is normal, and since you're not interested in the classical risk factor, or say you don't get the right persons, you would neglect the classical risk factors. But with regard to your imaging methods, you have just one point in a continuum with regard to the vessel wall of that particular person. Do I understand you correctly that if this test, whatever it is normal, and your patient has a cholesterol of 270 or something like that, and a high blood pressure, you would say it doesn't affect its vessel, so I don't have to treat that? I don't think we don't have the data to do that.
That's a good point.
Patients with high blood pressure all have abnormal elasticity. Patients who have white coat hypertension do not necessarily, but anybody with a diastolic pressure over 100 has evidence for structural and or functional abnormalities.
But let's assume he's right. Let's assume that he's right, and that test is not elasticity, it's calcium. Let's assume we've done that. We've done at age 45 and above, we started with imaging, and we did a calcium test, and it was not abnormal, but he has high cholesterol and high blood pressure. This is your question?
Well, of course. Traditional risk factors.
I think we're gonna put them on the same path as we pick below age 45, where you have found risk factors, you want to treat them.
Well, I don't have the data, and I understand that, but in the future, I believe that if your artery function and structure is normal, I don't think you should treat the cholesterol.
But the problem is, I mean, you're focusing on one point in time. You don't know for how long that high blood pressure
Well, that's why
is, or for how.
That's why we have to follow people up. We have to bring
So
them
you
up.
have to do continuous
Well, 5 years.
or repeated
if your
ECGs
arteries
or
are-
whatever it is.
If you're 50 years old or 60 years old and your structure and function of your arteries is normal, I don't think it matters what your cholesterol is. I mean, we have a poster girl that we use for our center, who was a 102-year-old woman that was published in the Wall Street Journal a couple years ago, who was pictured with a cigarette in her hand, and she's been smoking for 85
Yeah,
years.
but no, we can't talk like that in gala and fashion. That's one of these outliers sitting here. This outlier is good for Wall Street.
Well, that's
but not
right,
for-
but
Yeah.
it is possible to have risk factors, statistical
Yeah,
risk factors in the absence of disease. And if we could be more precise in defining individual risk rather than group risk, then we would be able to treat individuals without having to rely upon statistical correlation.
But I think we all agree that that population is not very high.
I mean, with regard, for example, with regard to microalbuminuria, which certainly is a strong risk factor for future
No, it's disease.
clinical disease.
It's
clinical
early-
disease.
it's vascular disease.
Yes, but mainly what we're interested in is clinical disease. I mean, clinical endpoints.
Well,
I'm not so sure. Is the association between microalbuminuria and clinical outcome, is it so much stronger than, for example, with the combined evidence of the Framingham score, for example, and outcome? I'm not sure about that.
Well, you can find individuals with microalbumin who have normal Framingham risk scores and vice versa. They both correlate with risk. The question is, are they additive? And I would suspect that they are, but it's very hard to get the data. And that's, we're trying to collect that data.
we don't have
That's
that
what
on
we're
that
trying to
one. I think we will go. I'm going to go back again and ask for everybody's help.
I think we have to ask ourselves how realistic and practical we want the results of this conference to be. If we want people to say, that's reasonable, let's consider this implementation, then as much as I agree with your suggestion, Mort, that everybody over age of 45 should have an imaging test, to start off with that, even in patients who are very low risk by conventional criteria, is not going to be taken seriously.
Can we look at here? Actually, I was going to tell you, this is not everybody. Everybody who falls over 50% of those two. So if you go 45 to 55,
I was just saying, starting off with imaging.
I was going to move towards PK's approach, because PK's approach is the radical approach. To start with imaging right off the bat. In 35 to 45, we're going to limit to just risk factor and not shift towards imaging. Imaging, not imaging test is required except for following familial hypercholesterolemia, premature CHD, long-term diabetes, that we can talk about it. But in the very early stage of development of disease, which we consider at 35 to 45, we should just limit ourselves to risk factors, CRP and Framingham or cholesterol for risk factors. And I was trying to get this definition through you, that can we come up with mistake, because here the absolute risk is just useless in this 35 to 45 range. I mean, you can't use absolute risk, but it's a good way to use relative risk and tell people, look, comparing to people your age, you are in at risk or high risk or very high risk because of your risk comparing to others are high, you have high cholesterol and so on. In this population, we do not have imaging. However, when you go to the, and of course that changes in female, we can be 40 to 50 instead of 35 to 45. But in male, 45 to 55 or whatever top we want to put on this, I think we now opened our way that if it falls in top 50% or 25%, we want to send them to the next step. Now, I put this coronary calcium imaging, talk about IMT and so on. Now, what would be the problem here, Harvey? You
Just realize what you've already done by incorporating age, as you have just done in Framingham. because you have now said the low-risk people, 35 to 45, get test X, and the intermediate risk people, 45 to 55 or 60, get test Y, and I'm sure you will have age 60 will get test Z. And you've all, so just realize what you've done.
Okay,
Don't say, where do you come up with these ages? You came up with these ages because we know statistically that 45-year-old male has two risk factors. Male, 45, two risk factors. Done, you know. So just
So
realize you are not,
Okay.
You're not
be
moving,
aware of what
you're
you're
not
doing.
moving the paradigm forward by doing this sort of thing. I mean, you're just going back to all the old data and finding a way to
That's one risk factor.
put
Well,
markers.
It's a one risk factor. Male,
What is-
Well, all right, whatever you want.
What is the frequency of abnormal calcium imaging below the age of 45?
In what population?
Depends
I
on
mean,
the
just
population.
general population.
Well, MESA, general population had less than 40% of all patients, 35 to 85, had any coronary calcium.
Oh, well, the answer to the question is extremely low.
Very
It's
low.
very low.
Very
Yeah.
So that's it.
So it's not a sensitive marker for risk in
But
somebody
there
under
is
the
no
age
risk.
of
How many? How many
No,
risks?
the risk
How
is
many?
low.
How many?
Risk
How
is
many
low.
why do we have
Kind of
before
skip the
45?
Well, I don't want, I'm not interested, I want to find the person who needs to be treated to prevent his MI at 65.
So what issue?
And calcium screening
Yeah.
in the age of 35 to 45 doesn't tell me
We don't want to
who
have
might
it.
have an
No,
event.
we don't want to have
Nobody
it.
You need to treat them for
None of
20
us have.
years.
I realize that, but, you know, and
No,
that's...
But Jay, your paradigm is that the only way to prevent the heart attack is to treat them for 20 years before they develop disease.
Correct.
That's not correct.
Well, see, I think we're.
You say the word correct, you're
Well,
probably
I said
incorrect.
that's my...
I realize that, but the science would say you're probably incorrect.
Because what?
Because good studies with aggressive management can show that you can stop most heart attacks even in established disease. So if we
Well,
take the post-MI patient and treat them aggressively and we can stop the next event, then we don't need to treat them for 25 years before their first event to prevent the next
Well,
event.
that's a very important issue that I think we need to address as to what's the importance of how early do we need to start?
But that's why I like
We
more
decided
studies.
35 was early.
I think
We're looking for
he
5-year horizons.
just echoed my 35 to 45 in a different language. You just said that there is no need for calcium
No,
screening because there is no.
It's not that low.
That's
Here-
what we're saying.
Here are the numbers. The paper published in 1993, age 40 to 49, 44% of men, 23% of women
Had what?
Those
have coronary calcium.
Well, have two picks.
But have some. I don't know the exact
Yeah,
range.
but what's the,
Well, I can
that's
tell you
not,
the range.
that is not the
30 to 39.
population. These are people who came for testing.
Right.
Right. The 30 to 39 group
That's
is
it.
21% of men and 11% of women. So it's
So-
low, but it's not.
It's not zero. Okay.
So the point is, let's just leave out imaging from population 35 to 45 and
Because
consider
they're low risk.
because whatever. Let's just
Well,
not
I
talk
mean,
about it.
that's
I agree with you.
traditional.
I agree with you. But we are now separating ourselves from traditional way by going after imaging right after 45.
Just realize you're introducing what all of us have written, but most people
That's
have
fine.
not understood.
That's fine.
Intermediate risk,
John,
which was written a decade
Yeah,
ago,
we-
but ignored.
I agree, and then if we come to exactly what you said and everybody agrees, we could do that. But one point is 45 and above, now we consider the basic cholesterol and CRP test, and whoever falls in top 50%, let's push them for an imaging. Now,
Before
what's
you
the
go to
problem?
that 50%, what is the, in the 45 to 55-year-old group, if you go back to these, like Prevention 5 conference, if you use the cutoff of 0.5% or less being low,
You mean absolute risk?
absolute. In other words, if you go back to these cutoffs of over 20% is high and less than 5% is low, if we accepted that less than 5% might be okay, how many infarcts would we miss, and is that against this eradication of heart attacks that we'd be interested in? In other words, I'm trying to pose a question. Are you trying to set up a structure where we are going to capture 100% of the people who are going to develop a myocardial infarction in the next 10 years?
Well,
Or are we trying to
we
catch
have to, yeah,
many of them?
as many as we
In
can.
which case, I would come back to what was said here before, and I don't know whether, even in this group, 45 to 55, whether you need to go beyond, whether it wouldn't be possible to screen out a very low-risk group that does not need to go on for further testing.
Okay, well, they fall in our initial 50%. And we don't do anything with them, just go with routine. We're not talking about treatment, by the way, today. We'll come back to what is the lifestyle modification and treatment. But the point is, in the screening path, if they fall in our top 50% or top 25%, is there any point to go for imaging? Or we go after what PK said, to start with an imaging. This is the point. I'm just trying
Okay,
to get...
so in this group now, 40...
The Framingham score then to determine risk. And statistically, you're on firm ground because we know there is a statistical correlation. But in terms of individual patient management
We're
and
back to square
biology,
one.
you're back to where you began.
Okay.
And I think that Dan's point is exactly right. Are we willing to just make sure we can pick up the 70% of the infarcts and forget the other 30%? Or is it our goal to individualize so that everyone who is destined to have an MI before the age of 80 can be picked up and get intervened on? And then the question is, as came up, should you intervene at age 40 in the absence of calcium, in the absence of symptoms, or can you wait until symptoms develop or calcium develops to begin therapy?
And my only point of that was that Mort's plan of re-evaluating them 5 years down the road, if they come out negative on the first pass, will probably catch most of those people
Well,
who will
it
eventually
may,
develop.
but, we all have
early
anecdotes.
Right, no, absolutely.
We have a 45-year-old man who went and got calcium screening, and he was 0. And he came into us, and we found advanced vascular disease with structure and functional measurements. And we told him he needs to be treated. He was very confused. 2 weeks later, he had an MI. Now, what the hell is all that about? Well, we understand what that's all about. He had a soft plaque, ruptured, had an infarct.
Yeah, and he was unlucky because he's one out of, I don't know, 1,000. He's not.
He's
in
one
our
of the
ranking.
5%.
Yeah, he's
Zero
one of
calcium scores who have
5%. He is.
Well, the negative
So we
predictive
know what
value
occurs. Now, do we
is
care?
99.
Should we say that's okay? We're willing to lop those off, or do we try to get individually everybody?
Well,
I don't think we can be greedy.
No, we cannot. We
95% is
cannot.
pretty
No, it's not 95.
Yeah, it's impossible at this stage to go for 100% accuracy.
But you have to go forward, not backward.
How many in this room, if you are one of them, you should be the first to say, is comfortable to start with an imaging at age 45 and after?
Structure and function, I'll
Ah,
modify that.
but let's not dream, because we don't have those, and we have today calcium score and IMT
But whichever test,
and
that's
MRI.
structure.
That's even more expensive.
That's structure.
What?
That is structure.
Yeah.
Imaging is structure. That's exactly what you're doing.
So you're comfortable to start with everybody at age 40 and above with one of these?
I would personally do it. I'm comfortable because I do believe that identifying disease is more important.
So independent of traditional
That's-
risk
I
factors.
think
No,
that's
no,
my view.
not
too.
in-
Okay, I really want.
I don't think it's MRI, and I don't think it's calcium screening. I think carotid ultrasound is one of
Oh, wait a
the
minute,
tests.
carotid ultrasound. Just having a facility to do carotid ultrasound accurately where you can rely on, it's not less expensive than $200 to $300.
Oh, yes, it is.
Well, the
Well,
testing
in
that I've seen.
the way we do it, we have all the instruments in one room. They come in
Yeah,
and
but
they get
let's be
everything done.
realistic. We're going to talk about the guideline that can go more than your lab. And my point is, the carotid
No,
IMT
everybody should replicate our lab.
Right. I love that. We will change this meeting to J. Cone meeting. I love this. This is
No,
great.
but I think Jay is making a very important point. I think we have to predict the paradigm and the change in paradigm and not get locked onto it. We have to take a contrarian approach. I really think that that is the way we can redefine.
How contrarian you want to be, though?
That makes good sense, and that's a testable
Yeah,
hypothesis.
I think exactly, this basically brings,
Yes,
this
but
should be tested.
This should be tested. We want to say that. We want to absolutely say that this setting or a like setting that is cheap, inexpensive, and reproducible should be tested because that's the way to go for future. But again, you missed the point is what can we do with today's tools? And we have calcium scoring. Now, my point was, are you comfortable doing that?
Yes, let me lay it on the table. As Matt just pointed out, going forward, the negative predictive value of a zero calcium score is 99.2%, which is...
When you say negative predictive value...
That means if you have a zero calcium score, your chance of having an event over the next 5 years.
Oh.
So you can repeat the scan, though.
Absolutely, yeah,
So
5
it's
years. Okay, so we...
99.2%. For the present,
Okay.
that is fabulous. So if you want to be contrarian, let's just say, okay, everybody above age X, which we still have to determine, should start off with a
Well, that's
calcium
what
score.
you're saying.
Now, okay, I didn't realize that you were willing to be
No,
so
we
brave.
are. No, we are.
Okay, wait a second. Cost. Let me talk about cost for a second.
$300.
In the Baltimore area, John Romberger told me, they are doing scans for $50. There are other places in the country that are routinely doing calcium scores for $100.
Yeah, CT scan dash 2000.
That
I'll bring it
changes
to-
the cost effectiveness paradigm dramatically.
Look at this one. I wish I had in my.
And in fact, Pfizer's going to subsidize the cost and do them for free because all these patients are going to be on a Norvastatin.
You need to be on Lipitor.
I don't have my...
And then what do you do if there is calcium, then next step is to what?
That's in our handbook.
Please look at this.
Let's start out. Let's go ahead.
This machine is going to come to your house, to your neighborhood, and this is going to. They're claiming they can bring it down to $200, and now they're not doing it right now, but it is very doable. So think about it.
See, the biggest problems I have with that is that who the hell taught them how to read these?
No, well, John, we will put your brain in a software and just copying all of these machines. Let's say PK is right.
I'm trying.
Let's say PK is ready, and he's gonna put his stamp on, and Jay's ready. And we want to say after age 50, everyone, starting with an imaging. Today we have this. Tomorrow we should have this. What Jay is talking about, because that's cheaper, more reproducible, and go everywhere, not just in big cities in the States. In the countryside of Texas, you can go where water
Better
just
have the
gets
paradigms to tell people what to do with this information.
then that's another step.
So as much as I advocate that, I advocate it when I do it and I sit with the patient because I know
John, we
I
want
do
to
a
get
good job, but I don't guarantee anybody else.
No,
will.
we want to get to that point, that what
It's
to
the
do
same
with this information. But the start point at age 50 and above, I want to put 50 and above.
What happened to 45?
He averaged the men and the women.
Something like this, between
No,
45 and 50?
Okay, 45. I'm just trying to be a little more. I'm scared.
45 for men and 55 for women.
Okay, 45 for men, 55 for women. Above, start with an imaging of structure and function. And today we have this. Tomorrow we should have this. What's counter argument?
The count. Now that if you're gonna go to that level, then there's no reason to not put in another $12 and get
Measure
basic cholesterol panel,
and CRP.
glucose, and CRP,
Because,
and blood pressure,
Well, I would argue with...
and blood
CRP.
pressure, and weight,
The
height.
modifiable risk factors.
Modifiable, yeah.
Whose benefits are assessed.
Right,
I agree with you. CRP
well,
is
wait.
not going to make blood pressure.
But and body mass index. The metabolic syndrome acts together more than all these other things. So that if you there are just too many. It's not as though
No,
a simple calcium measurement
Your
gives
injection
the whole
was correct,
picture.
and I think you made a good point to add to that one. And we can say until Jupiter is out, where we understand treating based on CRP would be
Treat the
good.
non-modifiable risk factors that have been shown to benefit.
Right, but
Right.
if Jupiter is out, and you know that if you measure CRP can help you with treatment, which is the whole
No, no.
purpose.
Let me give you some data. If you compare them to patients who have an average risk factor profile, no diabetes and no metabolic syndrome, who have a score of 150 on their calcium, the frequency of having ischemia, if you do an ischemia test, is higher in the patients with metabolic syndrome. It's as high in that group as it is in the patients who have a high calcium score and no metabolic syndrome. So I think you don't look just at the anatomic burden. You look at these those who, well, I know we're going to miss some pictures, but those, and it's not the ideal, but those who are over some low level of risk, let's call it 0.5% per year, would go on to an imaging test, it might sell. And it turns out that would lead to probably somewhere around 30 million people from the United States needing an imaging test. But I'm saying in order to be realistic to get approved for funding, I don't think you go in right away and say, give me an imaging test on all the patients. It's not taken yet. It hasn't been taken yet. And that's what this could come out. Why not support that statement?
This is what you're saying. You're saying start with the traditional and then go back and forth.
I'm saying start with the traditional rather than trying to put the point of starting with the imaging. Because I think if you put the point of starting with the imaging, you're going to get turned down by all the payers. Because they're going to say, even if you get it down to $100, you're costing me more than if I pulled it out. Simple screen would probably be. I don't think that there's an opposition to simple screening, but. You're going to get more people treated, and you're going to save a lot more lives.